Welcome back, Patriot. By now, you're basically an expert in the most common forms of aneuploidy, which means it's time to take a more detailed look at the chromosomes. We'll do that by reviewing two important syndromes, 22q11.2 deletion syndrome and Williams syndrome, which are each associated with small missing pieces of genetic material within an individual chromosome. Welcome to Boston Harbor, where about 250 years ago, a group of loyal patriots known as the Sons of Liberty staged what came to be known as the Boston Time Party. Yep, you heard that right. Although most books refer to it as the Boston Tea Party, the colonists actually pitched a huge quantity of time into Boston Harbor. I think I see the confusion. Time, like the herb, not time, like the human construct reflecting the unidirectional and inevitable progression of the universe towards entropy and decay. So, now that that's all cleared up, let's talk about the Time Party, and also 22q11.2 deletion. 22q11.2 deletion syndrome is characterized by congenital cardiac anomalies, palatal abnormalities, developmental changes, dysmorphic facial features, and immune deficiency. This syndrome is also known as DeGeorge syndrome or velocardiofacial syndrome. And we might use those names too, because 22q11.2 syndrome is quite annoying to say. Actually, we might even say DGS instead of DeGeorge. We're feeling lazy today. Anyway, here's another little-known fact. The name of the first president of the United States wasn't George Washington, it was DeGeorge de Washington. That's why all his buddies like Tommy Jefferson and Alex Hamilton called him Dee. Honestly, textbooks these days can't get anything right. Many of the associated facial features and anomalies result from abnormal development of the third and fourth pharyngeal pouches. Yeah, I see it too. Obviously, I know there was no T. It was all time. I was a history major, for God's sake. Yeah, I know. Yeah. Don't worry, we'll get the artists to fix it before we publish. Not a problem. The actual cause of all these anomalies is a microdeletion on chromosome 22. That means that there's a little tiny piece of chromosome 22 missing, specifically in the long or Q arm of the chromosome, and precisely at band 11.2. Keep in mind, the deletion is so freaking small that it can't be picked up even by high-powered microscopes, so you'll need a special test to detect it. If this is such a small deletion, why does it wreak such havoc? That probably comes down to TBX1, a gene located in the deleted region. Its deletion is thought to play a big role in the phenotype of patients with 22q11.2 deletion syndrome because TBX1 is typically involved in early development of the heart, palate, and thymus, among other structures. So, how are you going to pick up on this possible diagnosis? Well, before you even examine the patient, there are some clues that you might be able to glean from the patient's medical records. If prenatal records and history are available, take a look at the ultrasound results to see if there's any mention of congenital cardiac anomalies, such as tetralogy of Fallot or truncus arteriosus. More broadly, DeGeorge causes conotruncal abnormalities, which is why that colonel's trunk is getting jettisoned, along with the time. Lastly, if any abnormalities were discovered, the patient might have had prenatal microarray testing. We'll talk more about that in a bit. If you don't have access to the prenatal history, you might find some clues in the notes from other providers. For example, they might describe the patient as dysmorphic, or might note signs of cyanotic heart disease or hypocalcemia, which can present as shaking or tremulousness in kids. Other providers may even mention that the patient doesn't resemble their family members, though that might be more of a Dr. Phil type situation. Nope. That's not the Eye of Sauron, just a plain old malevolent lighthouse. I know the American Revolution was a long time ago, but the assault on Mordor by a brave and undersized fellowship was even longer ago. Again, I was a history major, trust me on this. And just as you trust in me, trust in this pulse ox lighthouse to remind you to check your patient's O2 sat, since they might have cyanotic heart disease and all. Regardless of whether that history is available, you're going to perform a thorough exam of the patient yourself. And these findings are super important and will help you diagnose your patient even before you get to gene testing. Specifically, you're looking for a mask-like facial appearance related to low facial muscle tone, a tubular nose with bulbous tip, hooded eyelids, hypertelorism, which is to say wide-spaced eyes, ear anomalies such as overfolded helices and asymmetry, among others, malar flattening, which just means flat cheeks, and a small and recessed chin or jaw. These patients may also have a frank cleft palate or bifid uvula. If you're suspecting 22q11.2 deletion syndrome based on your history or exam findings, you'll want to order diagnostic testing to rule in or rule out the diagnosis. FISH analysis picks up the majority of patients with 22q11.2 deletion syndrome, but does miss some patients with a diagnosis that harbor a slightly smaller deletion. So, microarray is increasingly becoming the gold standard to evaluate for this diagnosis. A microarray is a detailed study of the chromosomes that can identify very small differences in the amount of DNA throughout the chromosomes, including differences so small that they're missed on karyotype. While you're drawing blood for genetic testing, it'll be a good idea to go ahead and order serum calcium and parathyroid hormone levels to look for hypocalcemia and hypoparathyroidism, which can be serious complications of the diagnosis. Fun fact time. The first PhD in the US was awarded at Yale in 1861. But wait, as we all know, the Boston Time Party took place in 1773. So who the heck is this guy? Or maybe it really was a Boston Time Party. Like the other kind of time, the immutable march toward the hyperdispersion of the universe kind. Well, if there's time travel going on here, I don't even know what to say. My jimmies are officially rustled. Now is when we usually talk about a differential diagnosis. To be honest, given the constellation of symptoms and the ability of microarray testing to precisely identify the microdeletion, there's not going to be a lot on your differential. Still, there are other genetic syndromes that have similar phenotypic features that should be considered. See the differential diagnosis menu for more. With a diagnosis in hand, it's action time. The first step is to assemble a team of committed patriots and give them a cool nickname, like, let me think, the, Sons of Liberty. Those dudes were an early super team, like Crosby, Stills, Nash and Young, or the Avengers. But seriously, this is a very complicated condition, and you'll want a multidisciplinary team with a pediatrician, geneticist, cardiologist, and so on. From a patient management perspective, you'll want to order an echocardiogram right away to evaluate for those underlying conotruncal cardiac anomalies we discussed before, because most patients with 22q11.2 deletion syndrome have congenital heart disease. And since you've got the ultrasound machine off the shelf, might as well get a renal ultrasound to evaluate for renal hypoplasia or agenesis, or multicystic and dysplastic kidneys, among other possible anomalies. Look out below! And since immune deficiency is another common complication, go ahead and order a CBC with differential to check for lymphopenia. Specifically, you're looking for low CD3 positive T cell counts, so you might want to order a study for that as well. Speaking of low T cells, you should know there's some overlap between DeGeorge and the dreaded SCID. In a very small number of DGS patients, the thymus is completely absent, and T cell numbers are super low. You might even consider this so-called complete DGS a form of SCID, and these patients need management for SCID. Let me hit you with a little more history here. Up until the Boston Time Party, anybody of any age could drive any vehicle, which meant that everybody's boats and buggies always had these awful skid marks on them from where idiot 10-year-olds had scraped them on stuff. But then the Time Party happened, and when people started putting pictures from the harbor on Instagram, the boats all looked scuffed and terrible. So they instituted a permitting program for young vehicle conductors. And that's why you had to complete 100 hours of driving with your mom when you were 15. #history, #knowledge bomb, #blessed. While we're talking about While we're talking about the thymus, get a chest x-ray to look for the absence of the aforementioned organ, which is to say, you won't see the famous sale sign on your film. By the way, since we're going to all this effort to figure out if there's an immune deficiency, be sure to hold all live vaccines until the workup is complete. Even if frank cleft palate, submucous cleft, or bifid uvula aren't identified on exam, every patient with this diagnosis should be evaluated for possible underlying velopharyngeal insufficiency, or VPI. Velo what now? Yeah, that's what it's called when the palatal muscles don't move very well, which can lead the patient to have hypernasal speech or nasal regurgitation. I know that guy's jacket is supposed to look like a soft palate and uvula, but it just looks like he's naked with a weird butt tail. Man, the 1700s were different. About a third of patients with DeGeorge syndrome also have feeding difficulties, which may cause them to throw large quantities of food overboard. And you'll also want to order formal neurodevelopmental evaluations, since these patients have an increased risk of developmental delays in general, and speech delays in particular. They may also suffer from learning difficulties and autism spectrum disorder. Oh, good. Weird buttsuit guy doesn't even know how to sail his own boat. He's definitely going to end up in the harbor, and I do not envy whoever has to go rescue him and get all up and close and personal with that slimy butt coat. At some point, referral for psychiatric evaluation and support might be indicated, since adults with 22q11.2 deletion syndrome are at increased risk for schizophrenia, bipolar disorder, anxiety, and other mental health conditions. But it's important to emphasize the highly variable phenotype, with some patients being severely affected while others hold jobs, live independently, and have families. That said, remember that this can be a very serious condition. The underlying congenital cardiac anomalies and immune deficiencies contribute to increased mortality when present. Now, for the remainder of this sketch, let's shift our focus to the other microdeletion syndrome that we promised to review. Williams syndrome is characterized by elfin facial features, cardiovascular disease, variable degrees of intellectual disability, and a unique cocktail personality. It's caused by a microdeletion on the long or Q arm of chromosome 7 at band 11.23. Within that deleted region, there are some important genes like ELN, LIMK1, and GTF2 that are thought to contribute to the cardiovascular, cognitive, and cocktail personality phenotypes, respectively. There's a couple of other involved genes as well, but we won't cover them after this. Those genes are LOL, WTF, SMH, and JK. Okay, so how in the heck are you going to recognize a patient with this diagnosis? Well, there might be a couple of clues that'll come from the parents or other providers even before you see the patient. For example, the parents might report that the patient was irritable. They might even say, "My baby was more irritable than Governor Williams during the Boston Tea Party." If they do say that, kindly remind them that it was actually a time party or a time party. Now I'm confused which one it was. Parents may also mention vomiting during infancy related to an underlying hypercalcemia, not hypocalcemia like you'd see in 22q11.2 deletion. Or that their child has difficulty feeding, failure to thrive, hypotonia, and or sensory neural hearing loss. Well, no wonder Governor Williams was so irritable. It's pandemonium in there! In older patients, an extremely friendly personality might be described as one of the patient's prominent features as well. This is often referred to as a cocktail party personality. Make sure not to confuse this with a dive bar personality, which is more like sleep-deprived and angry. A detailed exam will also be really helpful as you consider this diagnosis for your patient. These findings are key because this is most of what you'll use to make the diagnosis outside of genetic testing. Some things you'll want to look out for that are characteristic of Williams syndrome include periorbital fullness, a short nose with bulbous nasal tip, and a wide mouth with full lips. Because these features are often seen together in young patients with Williams syndrome, they're commonly described as having elfin facies. Please note that the elfin descriptor is just for the facial appearance of these patients. They do not actually have long pointy ears, which we have included here only to remind you of Legolas and his kin. Williams patients may also have what's called a stellate iris, which is a star-like lacy pattern on the iris. As affected patients grow older, their facial appearance changes, and a long, narrow facial shape becomes more of a prominent feature. As with DiGeorge syndrome, ultimately, all roads lead to the lab for confirmation of the diagnosis. Testing options include FISH analysis or chromosomal microarray. While you're drawing blood for diagnostic testing, go ahead and check serum calcium levels too, since idiopathic hypercalcemia is common in Williams syndrome. And remember not to give your patients vitamins containing calcium, since their levels may be high already. Let me also offer some unsolicited advice here. If you're at a party where a butler comes in with a tray of milks and it's not a party for children, just leave. Things are about to get hectic and you want no part of it. Trust me. Again, the differential for Williams is not very long. That said, hypotonia, irritability, vomiting, cardiac disorders, etc., can appear in other genetic syndromes. So ultimately, you'll rely on microarray testing to make your diagnosis. See our differential diagnosis menu for more. After a long wait, the lab finally gets back to you and confirms your suspicion of Williams syndrome. What's next? There are a number of things that you should do right away to ensure possible complications are identified early and managed appropriately. It's super important to order an echocardiogram to evaluate for supravalvular aortic stenosis, which is the most common cardiovascular complication of Williams syndrome. Though you may also see supravalvular pulmonic stenosis, and other findings can also be seen in these patients. Check your patient's blood pressure. And when I say check the blood pressure, I don't mean slap a cuff on the arm and hit the button on the machine and go blank in your brain. I mean, think back to when you were bright-eyed and eager and check a full-on four-extremity blood pressure, since that supravalvular AS can cause pressure differentials. And what's more, these patients are at risk of systemic hypertension due to vascular changes, and particularly renal artery stenosis, so keep an eye out for that as well. Speaking of which, snag a renal ultrasound to evaluate for that renal artery stenosis, as well as potential structural anomalies, including ectopic kidney and renal hypoplasia or aplasia. Given the increased risk for strabismus, amblyopia, and refractive errors, patients with Williams syndrome should have formal ophthalmologic evaluation and follow-ups. In extreme cases, they may need a bionic telescope implanted in the eye, just like this deputy. I forgot the Revolutionary War was so steampunk. And don't forget to order thyroid function studies to assess for possible hypothyroidism. Over time, you'll continue monitoring any complications you've already identified, but there are some additional management considerations to keep in mind. For example, you're going to need to special order some Williams-specific growth charts to keep track of your patient's development, since these kids typically have short stature. Ongoing cardiology follow-up is also indicated, even in the absence of previously identified complications, since cardiovascular complications might not be apparent on the initial evaluation. Definitely keep an eye out for systemic hypertension, too. Formal neurodevelopmental assessments should be performed with early initiation of therapy support because of the increased risk of developmental delay and intellectual disability, although many kids with Williams have strong language skills and auditory memory. Most patients with Williams syndrome have joint hypermobility, but joint contractures aren't uncommon either, so be sure to monitor for these findings on serial exams. See, this is what I'm talking about. You offer a tray of milks, and all of a sudden some drunk dude in a wig who thinks he's a pirate comes swinging in out of nowhere. Like I said, when you see the milks, get out. And finally, one thing that is critical to remember. You should always order an anesthesia consult prior to surgeries because patients with Williams syndrome unfortunately have an increased risk of sudden death with sedation. Time to review what we've learned today. Get it? Time? I guess that joke kind of works better in writing. 22q11.2 deletion syndrome, aka DiGeorge syndrome, is characterized by congenital cardiac abnormalities, palatal abnormalities, dysmorphic facial features, and immune deficiency. This condition results from a microdeletion on the long arm of chromosome 22 at band 11.2, which causes abnormal development of the third and fourth pharyngeal pouches. Patients with DGS may have characteristic exam findings, including a mask-like facial appearance with a bulbous nose tip, hypertelorism, low-set ears, and a small jaw. They also commonly have cleft palate or bifid uvula. Patients may also demonstrate signs and symptoms of hypocalcemia, like shaking or tremulousness. DGS is formally diagnosed by microarray testing. Patients with DGS typically have low T-cell counts, and those with complete DGS have an absent thymus, which is a form of SCID. As they age, patients may have developmental delays, or learning disabilities or psychiatric disorders that require further attention. However, the disease has a very wide phenotypic range. 7q11.23 deletion syndrome, aka Williams syndrome, is characterized by elfin facial features, cardiovascular disease, and intellectual disability. Patients may also have sensory neural deafness or an extremely friendly cocktail party personality. They also have characteristic facial features described as elfin. These include periorbital fullness, a bulbous nasal tip, and a wide mouth with full lips. They may also have a starry pattern in the iris, called a stellate iris. As with DeGeorge, Williams is diagnosed by microarray testing. And as with DeGeorge, you should check a calcium, but in this case, it's for hypercalcemia. Patients with Williams should also have an echo to evaluate for supravalvular aortic stenosis. And finally, these patients may have short stature, as well as developmental delay. And just like that, we're done! Now, gather around, children, while I share one last historical tidbit. As you know, the Boston Tea Party was really the Boston Time Party, and as you know, it took place in 1773. That fateful day, nearly 100 patriots stormed the harbor and threw bushel after bushel of time into the harbor. And that's where the part of the story usually ends, right? Some taxes, a little Paul Revere action, DeGeorge to Washington, crosses the Delaware, etc., etc. Doth the star-spangled banner yet wave? Yay, America! But we're historians, damn it. Let's carry this thread a little further. So, there the time is, in the harbor. Time, at that time, was worth more than its weight in gold. And you, of course, know, being a student of medicine as well as of history, that an infusion of thyme was once believed to cure all manner of ailments, from dropsy to the hexes of witches to the warts of HPV. So, anyway, there are all those precious herbs floating in the sea. And the people of Boston, at that time being a resourceful, kindly lot, decided that this rare gift should not go to waste. And so, they cut the forests around Boston and felled the trees of the Berkshires and cleared Cape Cod. And they dragged all the wood down to the docks, where they lit enormous bonfires. And by the afternoon, the whole harbor was boiling. The sea was steaming. The infusion was ready to drink. One by one, the people of Boston came to the harbor to imbibe and thereby cure their ills. And though they were a determined people, the Bostonians were not gifted with wisdom. They had neglected one very important thing: the burning salinity of the sea. But nonetheless, they drank this briny brew, every man, woman, and child, until the very floor of the sea was visible. And as the water came rushing back to fill the void, they realized that their kindliness had vanished alongside their sickness. And that, children, is why, even today, the people of Boston are so friggin' salty.